If you've been dealing with back pain for a while, especially if it's been really limiting your training, then one of the things that you're thinking about the most is what you should actually be doing from a rehab plan or rehab program standpoint to solve your back pain and actually get back to the training that you want to be doing. And this is a really common question that so many lifters that we've worked with have had. And one of the biggest reasons is that there's just so much information out there on social media, on YouTube, on Google, and all this information has different prescriptions or recommendations for what you should or shouldn't do for back pain, how you should modify your training, if you should continue training, all this sort of stuff. So all of these different sources have so much conflicting information that it can make sifting through these different pieces of information and figuring out what you should actually do really, really challenging. And because of that, I wanted to make this little video to basically go over how to build an effective rehab plan for your back pain so you can actually get the results that you're looking for and not just have to rely on trying endless different things that you see online or relying on cookie cutter rehab plans or anything like that. So one of the most important things to discuss first is what actually does not dictate what you should do for your back pain or your back injury. And most lifters that I talk to typically think that the biggest factors that tell them or kind of direct what they should do for their rehab work is their imaging and therefore their diagnosis. So many lifters will get an x-ray or an MRI because of their back pain, whether it's because it's something that they feel they need, or they go see their PCP who recommends it, and they'll go get this imaging, and afterwards they'll very often get a structural diagnosis. And this is something like disc bulges, degenerative disc disease, arthritis, stenosis. All of these structural diagnoses or structural changes that are seen on MRI. And lifters will get these diagnoses and believe that that's what they need to have the knowledge of in order to guide their rehab work and dictate what rehab exercise they should or shouldn't do and all this sort of stuff. And I've talked with a ton of lifters who have gone through this process of waiting weeks or months to get an MRI or a piece of imaging because they feel like that's what they need to learn what they should be doing, and that's simply not the case. The issues with that are primarily that your diagnosis or your structural diagnosis does not dictate the plan that you should use to solve your pain and get back to lifting. And a big part of that is because, one, the structural diagnosis or structural changes in your spine or in your back are only one piece of the puzzle about what's going on. There are so many other factors that affect your pain and injury and performance. And the other reason behind this is people can have the same basically structural changes or structural diagnosis and require very different rehab strategies or rehab plans to actually solve what's going on and get back to training. And to illustrate that purpose or that point, we're going to briefly talk about two of my former clients, Anna and Sean, both of whom are barbell athletes, and they both had pretty much the same structural diagnosis. So they had both been dealing with back pain and symptoms down the leg for a while. They both saw their physicians, underwent x-rays and then MRIs, and the MRIs both show that they have L5 and S1 disc herniations. The issue is they're both very different people and they had different limitations and goals. Anna is a power lifter and she had flexion sensitive back pain. So for her, rounding her spine forward, flexing, and kind of hunching forward is what primarily caused her symptoms to become much worse. So for her, prolonged sitting, bending over to tie her shoes, and then getting into end range positions for squats and hinges, that's what really flared up her pain. And when we did her assessment, she had specific limitations. And those were primarily in hip and thoracic spine mobility, hip abductor strength and endurance, and also low back endurance. And this is in a bit of contrast with Sean, who is a actual competitive CrossFit athlete. And for him, even though he had that same diagnosis, his pattern of symptoms and limitations were very different. He had extension sensitive back pain. So for him, bending backwards is what actually triggered his pain, and bending forwards tended to feel better. So because of that, things like overhead pressing, push presses, the kipping portion of gymnastics type skills and CrossFit, those are really what triggered his back pain. And he could get into the bottom of the squat or the bottom of the deadlift or an RDL without really any pain or limitation. And when we did his assessment, he also had different limitations than Anna had. He primarily had deficits in hip and ankle mobility, hip adductor strength and endurance, and then his rotational trunk control or rotational performance. So because of that, these two lifters, even though they had the same diagnosis or the same like structural issue, they required very different plans because they had different triggers of their pain, different goals, and different limitations. And if I just took the MRI findings and gave them the disc herniation rehab protocol or rehab plan that every person with a diagnosed disc injury had, chances are they would not have had good results whatsoever. Might have been the right plan for one of them, the wrong plan for the other, might not have worked for either of them. But at the end of the day, because they are different people with different goals and limitations and triggers to the pain and like patterns of the pain, they required very different rehab plans. And when we implemented those individualized rehab plans, they both saw great results, were able to overcome their pain and get back to full training. So when we're talking about what actually makes an effective rehab plan, there are three main components. Those are individualization, the plans or programs are progressive, and they're also goal-directed. And we need all three of these factors to be present in order to have the best program possible for that individual person. If any one of these are missing, then we're going to be missing a good bit of what actually makes a program effective. So when we're talking about rehab plans, one, when we have a lack of individualization, we tend to get very cookie cutter rehab plans. So this is, you go to the physical therapist, you're diagnosed with a disc injury, they give you press ups, hamstring stretches, hip flexor stretches, things like that. And that doesn't work out well because those specific drills might not actually be targeting what you need to work on in order to overcome your injury. On the other hand, things need to be progressive over time. It's just like with your training. Rehab and training, or rehab and lifting, are very similar in that whatever you're doing needs to be hard enough to actually drive adaptation and progress you forward. And if the plan is not progressive, let's say they just have you doing bodyweight planks, bird dogs, and dead bugs, which are the very stereotypical back pain program or back pain protocol for lifters, then you may see some progress in the beginning while that is challenging enough to actually build up strength and endurance and all these sorts of things. But as you continue to train that, you're going to develop strength and develop endurance. And just doing those same bodyweight drills a week or 2 or 3 down the road is probably no longer going to be effective, and you're going to plateau and you're not going to make any further progress. Whereas on the other hand, if the program actually is progressive and it starts at a challenging level and then it continues to progress in volume, intensity, exercise variation over time, then it's going to continue to help you develop your strength and endurance and whatever qualities you need for your rehab work and actually get back to 100% or as close to it as possible. And the last part is it needs to be goal directed. If the goals that your physical therapist or your healthcare provider has are very different than what your goals are. So if you want to get back to heavy squatting or deadlifts or cleans or whatever type of training you want to be doing, and your healthcare provider, their goal is just to get you back to daily activities without pain or limitation, then there's going to be a big mismatch between the type of program you get and the results they're looking for. So ultimately, you need each of these three components: individualization, a progressive nature of the plan and program, and a goal-directed nature of the plan and program to have the best possible chance at reaching the goals that you have for yourself and actually overcoming this injury. So speaking of that, there are many different determinants of a rehab plan, as you can see here. The two kind of big categories are training factors and then your specific deficits and limitations. And both of these are going to play a really big part in determining what you should do and how you should structure and program your rehab plan. So for training factors, we have obviously your style of training, which lifts are painful or which lifts exacerbate your back pain, and then what your goals are. For deficits and limitations, we primarily look at flexibility or mobility, strength, and endurance. And the important thing is that when we look at these deficits, we're not just looking at the low back or the spine itself. We're also looking at the shoulders, obviously the spine and the core or trunk, the hips, knees, and ankles, because all of these areas will have an impact on how you're moving and how you're loading your back during exercise, how efficiently you're getting into certain positions, and how efficiently you're able to transmit force into the bar. And all of those factors will have an impact on how much overall stress your back undergoes while lifting. So when we find notable deficits in any of these areas, then while we may not know with 100% certainty that it's causing your back pain or anything like that, what we can do is try to address that deficit as we're modifying your program and doing other things in your rehab plan, and ensuring that we're checking all the boxes possible and actually doing everything that we can to get you back to 100%. So when it comes to training style, we typically work with barbell athletes. So some of the big training styles are powerlifting, weightlifting, and like strongman or CrossFit. And I kind of lump those two into one category because they have a lot more of a like mixed bag of what they need as far as physical performance. So with powerlifting and weightlifting, they're both sports where the end goal is 1 rep max performance. So because of that, arguably low back strength or maximal strength is a little bit more important than low back endurance. You're not doing as much high rep training with these two lifting styles. Whereas in strongman and CrossFit, you can have both a need for like 1 RM or really high intensity efforts, as well as more like higher rep max efforts. So you need a good blend of lower back strength and endurance, and that's going to dictate how you actually program direct lower back training. On the other hand, as far as range of motion and flexibility and all that stuff goes, with powerlifting, you need fairly moderate levels of hip, knee, and ankle flexibility. You don't need to be able to squat ass to grass as you would in weightlifting or maybe CrossFit, which would require higher levels of overall lower body flexibility in the hips, knees, and ankles to actually be efficient in how you're moving and training in those different types of training styles. Weightlifting, we're talking Olympic weightlifting, also has much higher shoulder flexibility demands because it is a fully overhead sport. And if you're really limited in your shoulder range of motion, that might have some impacts on how you're stressing the back when you get into the overhead position of a snatch or a jerk or a press. And in strongman or CrossFit, you typically need moderate to high levels of flexibility in those different areas, just because of the wider range of movements, the more overhead demand, and all these sorts of things. So because of that, your training style is going to dictate what needs you have, and those needs are going to dictate what strategies you need to utilize or how far you need to train each of these different types of qualities. Next is the painful lifts. A big part of a really effective rehab plan is how you're modifying your training around your pain and injury and how you're progressing that over time, and how you're implementing specific rehab work targeted to your deficits. So if you don't have both those factors, then you're missing a big kind of piece of the puzzle. So let's say squats and deadlifts typically cause a lot of back pain, whereas RDLs and snatches might not. In that case, you'd want to find ways to modify the squat and deadlift, and probably wouldn't have to modify the RDLs and the snatch. So you can modify the volume, intensity, tempo, range of motion, variation. And I made another video that goes a lot more into depth about how to actually modify your training around your injury, which I'll link below in case you want to watch that. So kind of want to go through a checklist, find out which lifts typically aggravate your back pain, and then find ways to modify those lifts so you can train with minimal to no symptoms and then progress it over time just back to your regular style of lifting. And then as far as deficits goes, again, we primarily look at flexibility and then strength and endurance. Stability is not so much a factor that we tend to look at. Stability tends to be more of something that's impacted by pain necessarily than what is causing pain itself. And it's just a lot harder to measure stability than it is to measure strength and endurance. So we go about assessing these deficits in two ways. First is we assess the flexibility and mobility of our clients on an actual video call, so we can see how they're moving. We can take them through a bunch of different tests and assessments of shoulder flexibility, lower body flexibility, spine flexibility. And then we do specific performance testing based upon their style of training and what their initial kind of pain pattern is. And we'll go into a little bit more depth into each of this. Again, how we actually pick which tests to do and like what we're testing and how we're testing is going to depend very much on the person themselves. So there's no one size fits all approach for testing, just as there is no one size fits all approach for how you implement a rehab plan for somebody with back pain. So for flexibility testing, the kind of big areas that we look at are the lats, so overhead flexibility, the flexibility for the thoracic spine, hip flexibility in a bunch of different planes of motion, so flexion, extension, rotation, and abduction typically. Obviously the lumbar spine itself, so lower back, and this is usually more so limited by pain than it is true limitations in flexibility, like from a tissue perspective, but it's a good way to assess it at the beginning and then use that to track progress over time. Ankle dorsiflexion is a big one, especially in sports like Olympic weightlifting, CrossFit, and strongman, where you need much deeper ranges for squats and cleans and snatches. And then knee flexion is something that we look at, but it's not one of the most commonly limited parts of range of motion or parts of flexibility. So for most people, we typically don't assess it, but in certain cases, if they have a pre-existing history of knee injuries or anything like that, then we will look at it because it might be impacting positions and how efficiently they can get into different parts of each of those lifts. For strength and endurance testing, we create a testing sheet for each of our clients that goes over specific tests that we want them to do based upon their training history, training goals, and what we've seen so far in their movement assessment. So this is just kind of a little example of that. So we have this Google sheet where we put the test here. It shows what exact test to do, has a little video demonstration, has notes on the side on how to actually perform the test, if there are any specific cues or tempos or anything like that that we want our clients to use to make the testing process as standardized and accurate as possible. And then there's an area where they can input their results. So some of the big movement patterns and muscle groups that we'll test are the adductors, the abductors, the paraspinals, which are those big muscles along either side of the spine and lower back, the obliques, the rectus abdominis, or like the abs, and then the glutes or the posterior chain. So for the adductors and abductors, we'll often use something like a Copenhagen plank and reverse Copenhagen plank, or we might have them do actual reps of Copenhagen raises and reverse Copenhagen raises, depending upon their history of doing direct abductor and adductor training. If they don't have a bigger history of that, then we'll probably go with the plank variation, because it's going to be a little bit lower of a barrier to entry, and then we can progress them to the dynamic test over time. For the paraspinals, we typically look at lower back endurance. So we'll have our clients do something like a Sorensen hold, where they get on a GHD, ideally, or a bench or 45-degree extension, and then they hold that fully kind of extended or fully neutral position for as long as possible before they start to round their back and get out of that testing position. And this one, the Sorensen hold, is a little bit different than the other tests in that we're mainly looking at how long can they hold that position in total. Ideally, what we want to see is about a 3-minute hold before they start to kind of fail the test and get out of that position. And that's different than the other tests for the abductors, adductors, obliques, all this sort of stuff. Because for those, we're mainly looking at side-to-side differences. So when we look at that, we might look at side-to-side differences in either low rep strength performance. So for the glutes or posterior chain, we might have them do a single leg hip thrust, 5-rep max or 10-rep max, and see what sort of load they can utilize for each side. For the adductors and abductors, again, we might do Copenhagen and reverse Copenhagen planks or dynamic reps and look at how does one side compare to the other side. And similar with the obliques, we might have them do a standing Pallof hold or some sort of resisted rotation exercise and look at side-to-side performance. And with those side-to-side tests, typically speaking, we're not looking at like absolute values. So whereas with the Sorensen hold, we're looking for them to get a 3-minute hold. For these, it's a lot more individualized. And really what we're looking for is a 10% discrepancy or difference between sides or less. If we see something like a 15, 20, 30% difference side to side, then we're a lot more confident that's probably contributing to what's going on and definitely something that we need to identify and address in their rehab plan. Whereas if it's 10% or less, then we're much less confident that's either causing or contributing to what's going on. And while we may still address it and try to improve those absolute numbers in their rehab plan, it's not something that we're going to attack as hard or as aggressively as something that has a much larger discrepancy between sides, because we are naturally asymmetrical to some level. Most of us don't have 100% symmetry between strength or endurance between our arms or legs or even our core on one side versus the other. So we look for bigger disparities side to side to really guide that more individualized rehab process. So in a nutshell, that's kind of how we identify what we need to do for each client from a rehab plan perspective and actually develop that program. It's very individualized to their injury, their pain patterns, their deficits, and their goals. And we do all these different types of tests to figure out what their exact limitations are. And we program the first iteration of their rehab plan to directly attack what we find are likely the bigger contributors to what's going on. And then, just like any other form of training or programming, we're always reassessing to make sure that we're actually making progress with these different measurements and adjusting the plan as needed and progressing the plan over time so that they can actually continue to make results over time or make progress over time. So for example, if we find that somebody has a notable discrepancy in their adductor performance on one side versus the other, we might have them start with bodyweight Copenhagen planks for specific periods of time, and then work up to loaded Copenhagen planks, and then dynamic Copenhagen reps with their body weight, and then continue to add external loading over time so they can continue to build up the adductor strength and endurance and even out that discrepancy side to side. So there's a lot to kind of unpack when you're trying to figure out what you should specifically do. And unfortunately, it's usually not as easy as just going on Instagram or going on YouTube, finding a drill or finding a plan that somebody made that's not individualized to you, implementing it, and seeing great progress. It's possible that that may happen, but in most cases, you need a much more targeted, individualized, and progressive plan to actually see the results that you're looking for. So if that's something that you are looking for, then just click the link below, just request a free phone consultation with me and my team, and we'll see if we can help you out. And if we're confident we can, then we'll outline what your rehab program would initially look like and what the process of working out would be like, and see if we can get you back to lifting.